Blog Talk Radio.
And that is my cue. Welcome, everyone. Live from San Diego, California. Welcome to This Week in Accountable Care. I am your host, Gregg Masters. And our show is brought to you by Zanate Media, the publishers of ACOWatch.com, a go-to resource monitoring the birth of the accountable care industry. We're broadcasting on Tuesday, September the 18th, 2012, and may I say that I am stoked, as we say here in San Diego, by the standing and the CV of the man joining me today. He is an innovator and thought leader with an impressive history of introducing and driving payer and provider-side change in competitive healthcare markets. His resume is a literal deep dive into the critical paths informed folk arguably associate with creative change in the healthcare delivery and finance space. Charles Saunders MD is president for strategic diversification at Aetna, where his responsibilities include the incubation, launch, and oversight of non-insurance healthcare businesses that build on Aetna's core strengths and address fundamental needs in healthcare. His experience spans healthcare business operations and clinical care in the U.S. and abroad. Before joining Aetna, Dr. Saunders was an executive in residence with the global private equity firm of Warburg Pincus, where he advised the firm on healthcare services and information technology investments. Prior to Warburg Pincus, he served as chairman and CEO of Broadlane, a technology-enabled hospital supply chain, group purchasing, and clinical workforce management company. Dr. Saunders also served as the president of Healthcare Global Industry Solutions for Electronic Data Systems, now part of HP, chief medical officer of Healthion and WebMD since their early days as a startup, and was a principal with the management consulting firm of A.T. Kearney, focusing on payers and healthcare systems. As a provider, Dr. Saunders held numerous leadership positions in healthcare delivery systems, including roles as an emergency department director, EMS medical director, and executive director of a physician hospital organization, where he focused on implementing hospital physician integration, managed care, and capitation. Dr. Saunders has served as on the faculties of the University of California, San Francisco, Vanderbilt, and the University of Colorado as a practitioner, teacher, and researcher. So I assume that we have Dr. Saunders on the line here. Is that correct? Let's see now. Dr. Saunders, are you with us?
Yes, I'm here, Greg.
Oh, excellent. Okay, glad you can make it. I don't know if you heard that background, but I was spewing out how impressed I am with your travels through the healthcare space.
Well, thank you. It's a generous review. Thanks.
Well, thanks. And so I was sharing with Brian before we went on the air. I was trying to catch you at the WLSA meeting when you gave your presentation. So let me give a little summary of that, and then some context, and then we'll kick it over for you for your take. My first opportunity to hear you was during your keynote at the Wireless Life Sciences Convergence Summit in San Diego in May. And during your talk, you quoted some numbers which literally blew me away. Most notably was the backlog of health system interest in working with Aetna in the accountable care or patient-centered medical home domain. Fortunately, I was recording your remarks, so I can quote your exact words within the ACO PCMH narrative. While itemizing Aetna's core competencies and preferred market engagement, you track back to Medicare Advantage, derivative Medicaid PCMH interests, the growth of Aetna-only ACOs, and multi payer ACO and PCMH initiatives, and then the formation of the Accountable Care Solutions Group. And you conclude with, and we have a pipeline of about 180 health systems. Again, this was back in May. So I was stunned by your remarks, in part because we are still laboring somewhat under a malaise that ACOs are, quote, destined to fail. Their HMO-light nature just didn't warrant the assumption of risk. Startup costs were too high. Risk-reward relationship was inadequate to stimulate engagement, etc. So your talk peeled back the curtain somewhat and gave us first-person insight as to the true market demand for these innovative financing and delivery system vehicles. So let's start at the beginning. Tell us a little bit more about you, your mission at Aetna, and what are some of the components inside of the Diversification group at Aetna.
Okay, well, certainly, Greg, thanks. I head up the Emerging Businesses Group, which we formerly call Strategic Diversification, which is the effort by Aetna to both create and acquire businesses that are non-insurance businesses that catalyze the transformation of healthcare. And the goal really is to partner with providers and engage consumers to make healthcare better, more affordable, more satisfying, and just deliver more value. I think we realize that there is a transformation underway in the U.S. where risk is shifting to providers, and there's a greater consumer interest and focus on the user experience, transparency, affordability, and quality, and that the health insurers need to leverage the tremendous assets and information and capabilities they have to be part of the solution rather than part of the problem. And Mark Bertolini has been a visionary and way out in front of this, and I think the company has really made an investment into trying to create new business models that will help catalyze this transformation. So that's my group. And we both have an incubator function where we create startup companies. And we also have an M&A component where we identify growing companies that are creating novel solutions for healthcare with a focus on providers, consumers, and HIT. So that's what we're about. We started this in February of 2011. We're up to about 9 companies now. 2 of those have been previously acquired. One of those is Medicity, which is the leading health information exchange company in the U.S. Another one is Active Health, which was acquired in 2005, which I believe to be the leading clinical intelligence and disease care management solution in the U.S. And then we've proceeded to start the Accountable Care Solutions entity, and that was started in March 2011. And we acquired a company called iTriage, which is a patient engagement mobile solution that provides access, navigation, and decision support for consumers broadly to move from symptom to provider. And then we've been in the process of building half a dozen or more other companies that add value to different components of the healthcare system. So we've been pretty busy for the last year and a half, and but I think that your interest in the Accountable Care and PCMH solutions really builds off of the growing experience that I had talked about at Wireless, which is now to date numbers more than about 70 patient-centered medical home-like entities. The majority around Medicare Advantage, but a growing number with Medicaid and commercial instances. And we're heading down a path to roll out a new business approach to this that will provide a lot more scale behind this so they can be implemented more quickly and easily and with a very robust engagement of the individual and the member. So we're very, very excited about that. In fact, we just published a paper in Health Affairs in the September issue where we reported on our experience in terms of cost, quality, and outcomes with one of our earliest ones that was done up in New England that showed a very significant reduction in the cost of care and improvement in things like a reduction in days per thousand and readmissions while improving quality scores. So we've had a growing experience with that, and then we saw a shift in the market going from maybe 2 years ago an interest in say primary care oriented patient-centered medical homes to now institutional involvement. So facilities and IDNs starting to weigh in and get involved and form the Accountable Care Solutions Group really around that movement to actually implement and commercialize accountable care solutions, not just limited to the Medicare definition of it for Medicare fee-for-service, but more broadly addressing the paradigm of accountable care, which is really provider organizations, both facilities and physicians, taking holistic responsibility for a population of patients and managing the total cost and quality and satisfaction of that patient, focusing on the continuum of their care, not only for episodes of care, but also in the white space between visits, their health and wellness, and total well-being, and then rewarding them financially based on quality, costs, and outcomes that really span the continuum of care, rather than just simply units of service. So it was that paradigm that we were really after, and seeing how we could apply it not just to Medicare, but to every patient population that a delivery system might take care of, so that they create one infrastructure, and then they can use that infrastructure in a completely payer-neutral way for every patient population, whether it's Medicare, fee-for-service, Medicare Advantage, Medicaid, their own employees, their commercial populations. And then what's most significant about what we've been doing is to allow them to actually go directly to employers with their own ACO product, branded to the delivery system, and eventually directly to the exchanges. This is a very disruptive approach, and I think it's important for delivery systems because if the end game of an ACO is successful, it will empty out beds. It'll increase capacity. And what the delivery system will look for is the ability then to take care of a larger patient population, and then they can do that by taking their branded ACO directly to market. And this provides, I think, a win for everybody. It provides a lower cost of care, a higher quality care, and it also brings a branded group of doctors and hospitals that everybody knows directly to the marketplace. So this is a more extensive and extensible vision for the evolution of accountable care beyond which was just codified in Medicare fee-for-service. But we've had a great deal of success with that, and to date we're probably involved in fairly deep implementation of about 1 to 2 dozen large institutional multi-payer ACOs around the country. Some of them have been publicly announced. About the Banner relationship. Inova is another one. We've done Carillion is another, and another group will be announced soon, and that we are engaged in active conversations with close to 200 health systems around the country that have aspirations for making this transition to accountable care and under various types of models and the realities of their own geographies. So I'll pause there.
That was fascinating. So, and a lot of information. That's what struck me about San Diego, as you were on stage and you were just putting out just incredible information. And I was fortunate to be recording it, but I was trying to jot down notes as well, because not just the growth and demand for accountable care support was notable, but also some of the results that you were reporting, which were rather which argued against some of the panning that's been going on about accountable care, too light, not enough incentives, so forth, to really make a difference. But some of the results that you're reporting are rather significant. So it looks like what you're doing over in the diversification side is basically building this ecosystem to perhaps put all the levers out there that had they been available when Healthion launched way back then, they might have had actually a shot of pulling off their vision. Is that a fair statement?
Yeah, I was fortunate to be at a point in time in history where I got to participate in the 1.0 version of affordable care, which is managed care, and then the 2.0 version, which is much more enlightened and has learned from the 90s. So during the 90s, we had provider organizations pursuing a concept that had conceptual merit to it for aligned incentives, but without the tools to really deliver it. And also oftentimes contracting out of fear that the payer was going to divide and conquer, and then if they didn't contract, that their competitor would get it. And they didn't really have the technology infrastructure to really understand and manage risk. And the financial rewards didn't provide enough profitability so that they could manage through that transition. And then at the same time, Medicare was not involved. They weren't in the game, and that patients were not robustly engaged in this. And so there was a backlash. It seemed like restriction of choice. So we've been there, and we learned all of that, and there was a chance to take some of the best that was there and combine it with technology tools that at that time didn't exist. We started Healthion with the goal of applying the internet to the workflows in healthcare, but it was a time when very few physicians actually had high bandwidth connections, if any at all, to the internet. And so we were educating and we were building as much as we were offering solutions. Now, 15 years later, the world is different. The internet's part of the fabric of the way that we do business. High bandwidth connections are widely distributed. The world has gone digital in healthcare thanks to the era of stimulus funding, and there's a transformation of the way that physicians practice that's underway to electronic healthcare records. And we have robust health information exchanges. So if you can think of Healthion 1.0, Medicity now is kind of the realized vision for what was possible there, where they have now, they're at about 27% of all the health information exchanges in the United States are Medicity. They connect over almost 1,100 hospitals, and in one way or another, 260,000 physicians, and they have an enormous number of clinical transactions rolling through their pipes. So having this infrastructure of connectivity that actually allows data to flow and actually involves real work and coordination of care to occur in a healthcare ecosystem was a missing element, and now we have that. And then the next layer that was missing was clinical intelligence. You need to, on top of that clinical dial tone, you need to have some kind of intelligence that can actually make sense of what's going on with both the population and with an individual, and then recommend interventions that are going to reduce the cost of care and improve quality. And then at the same time, then engage providers to do care management, not just episode management, but care management across the continuum. And there are now robust services and programs available for that. So what we're in a position to do, and what we've been doing, is to provide a fully integrated stack of all these capabilities as a turnkey solution for accountable care that can be flexibly applied to every patient population. So yes, I think we have the opportunity to have learned from the 90s. I think now we have not only the robust technology that we can apply to this, but we also have the enabling legislation that's come out of the federal government, and we have Medicare that is now weighing in as part of the solution, which provides a huge incentive for health systems to get on the bandwagon.
And that's perhaps the macro carrot here, is that while these institutions are re-engineering and reinventing themselves, if you will, through partnered relationships with payers or morphing payers such as Aetna, who's much more than just a traditional payer, they can create a glide path that enables a transition from, I got to fill my beds, to proactive participation in a savings against a budget.
That's right, and they have multiple ways that they can supplement their fee-for-service economics, assuming that they don't migrate to capitation for some time, if at all. And those would include things like care management fees and a share of savings, and even the increased in business that comes up from expanding the patient population that you serve by creating your own private label health plan products, or when I say health plan products, your ACO products that you take directly to employers and exchanges. So there are multiple ways that they can benefit economically that keeps them healthy through this transition.
So there's a lot of moving parts here. Where do you see the key levers? Are they with, for instance, as far as the ACO interest goes, is it with the Pioneer Group? Is it with the Advanced Payment Program, where you've got primarily less risk-savvy physicians engaged in the process? Is there any particular series of levers here where you think you'll see the most, the quickest level of change and engagement?
Well, I think that the Pioneer Grant and the MSSP program was a huge impetus to a lot of this. I mean, we started with Banner, for example. We had started with Banner with a commercial a private label ACO opportunity with them that we were working on together, and then they were awarded a Pioneer grant, and then this just created a tipping function where it was time to really more broadly engage. And because, as you know, the revenues from Medicare for most health systems are 50% or more of their total revenues, even though it's a smaller percentage of the patient population. So once Medicare is involved, and there's a path to forward, and if they don't do it, they still have to deal with a lot of structural changes with Medicare, pay for performance, and the episodes of care, and the penalties that come from not managing readmissions, et cetera. So the world is changing, and the opportunity to get involved in gain share and savings for the investments that you're going to have to make anyway was an important stimulus in this. So I think that was a tipping function, but I think also just simply the combination of the maturation of the digital infrastructure in healthcare with the ERA stimulus funding, the rush to get meaningful use dollars and implement electronic healthcare records in a way that they were, that was, there was some economic incentive to do that. Given the fact that they were probably going to do that anyway, because people conceptually understand that it's going to be necessary for the future of healthcare. That was another tipping point, and I think just having a large payer partner who was really willing to go at risk with these providers, saying that we believe in this future, and that we want to partner with you and make this future come true, and we'll do it in a completely payer-neutral way, and we will go at risk. We, Aetna, with our balance sheet, will go at risk alongside you. And we'll pay for implementation of a lot of the infrastructure components, so that we're completely aligned in our incentives. So I think all of those were important elements that just came together at the right time.
And then that's amazing. You said the magic word, payer neutral. I mean, that's such an evolved level of thinking that I don't know that many people necessarily appreciate that in the manner that what's different today versus back in the 90s, as an example.
I think you're absolutely right. I think in the previous regime, the evolving business model for creating value in the payer side of the equation was trying to get deeper and deeper discounts with providers. So assemble local market share clout, so that then you could negotiate a lower unit price with the docs. And if you're wildly successful as a health plan, that you'll drive out every last nickel of profit from the healthcare system, and then turn around and offer a very low price product to the marketplace. I don't think that's a sustainable business model, because the provider organizations, they need to have money to reinvest or to invest in the future of healthcare and IT services and care management, et cetera, and you can't achieve that by driving the unit prices down below the point where they're profitable. So we felt that it really had to be a collaborative partnership where everybody was allowed to win in that, and that Aetna is the third largest health plan in the U.S., has vast capabilities, but it has very, very broad national coverage, but the business model had never been to go very, very deep in a particular market, because we generally had historically served the large national plan sponsors. So our coverage was, maybe 8 to 10% share on average across the marketplace. So we're not really a threat to anybody in their business model, that where they have market share dominance. Aetna really had evolved through developing deep capabilities in medical management, care management, disease management programs, technology infrastructure, and those are the capabilities that we brought to bear and we brought to the table with providers in a truly collaborative way that was payer neutral. I mean, it's the only way that we're going to all collectively fix the healthcare system if we put some of these competitive differences aside.
Let me ask you this. Why do you think it took so long for our collective industry, and by that I mean both payer and provider side, to come to the awareness that our business isn't as simple as my revenues are your expenses and vice versa, that this really is an ecosystem in which we have mutual interest to find sustainable models? So, A, why do you think it took so long to come to that realization? Well, let me ask you that. Why do you think it took so long?
I think that's a good question. I think the reason is that I think that there was there was a conceptual understanding of population health management back in the 90s that evolved out of the HMO experimentation, that had gone on for a couple of decades. And I think we had a collective wisdom that was a better alignment of incentives, and it was more holistic, and it promoted health and wellness, which is where we needed to get to as a population. But we didn't have a lot of the tools and infrastructure in place at that time, whether both technology, we didn't have incentives aligned properly, Medicare wasn't in it, and patients weren't engaged. And it took a couple of decades to work through all of that for the technology infrastructure and the internet to be laid down, and eventual evolution of understanding of Medicare and the decision to weigh in, because we're facing healthcare growth that is really going to bankrupt the country. Where the unfunded Medicare mandate, it would be the fourth largest GDP in the world if it was a standalone country. Where at 20% of GDP, it's just unsustainable. Where that every airplane that's built, there's first 30 or more $1 million of it for some of our large airplane manufacturers goes to paying for healthcare, and where say China and Brazil don't have that issue. It's just unsustainable, and I think the confluence of these forces, created an ideal time for this to occur. And I think at the same time, when we saw the healthcare legislation and the potential migration of individuals to the exchanges, the migration of risk to the providers, it was pretty clear that the traditional indemnity insurance model of the 20th century really was less relevant in the 21st century. In fact, probably a dinosaur, and that we really needed to change the model so that we could migrate towards population-based healthcare in partnership with providers and in partnership with consumers. And so the confluence of all these factors, I think, plus Mark Bertolini's vision as a CEO, really galvanized us to take that bold step, and it's been paying off.
So perhaps we're coming back to a managed care 2.0 or a managed care 3.0 iteration on what we started back in the 80s and 90s. How will the announced acquisition of Coventry Healthcare affect the grand plan here?
Well, I think it's beneficial to us for a variety of reasons. One, it increases our depth and presence in the government sectors of healthcare. So more Medicare and more Medicaid depth, which means that we've got more value that we can bring to providers that are looking for more patients and just more girth in dealing with their Medicare lives. It gives us broader geographic coverage, so it fills in some geographic coverage gaps that we had. And it also just provides us with more economies of scale. So I think it's all good. I would actually point you to Mark Bertolini and Joe Zabreski to describe the details of the benefits there. It'll be a while before that's part of Aetna, but we're looking forward to examining the opportunity and see how we can drive the accountable care business further and faster with that asset.
Will do. And I actually listened to their conference call, and looks to me like there are enormous synergies there. Not the least of which is the genesis of Coventry, which was second and third market tier oriented, and they did a lot of private label and joint venture development for local nameplates, as opposed to necessarily putting their brand in the market per se. So it sounds like there's a lot of innovation there as well. So we're coming up on the end of the program, and I was wondering if you had any concluding thoughts. Are ACOs here to stay, or do you think, as the naysayers say, it's too little, too late?
Well, I think we're building the airplane as we're flying it, and I think that we'll probably we'll learn as we go and make tweaks and adjustments and so forth. But just given everything that we've seen, I'm absolutely bullish on where the future of healthcare is headed and where this movement is headed, and so we're going to stay the course and just go faster and deeper in it.
Well, I want to thank you for your time. There's so much that you have to offer, and trying to fit it in 30 minutes is virtually impossible. Again, this is Dr. Charles Saunders. He's President of Diversification for Aetna, and we chatted with him today about what Aetna is doing in the ACO and the PCMH space. We do this weekly on This Week in Accountable Care. Please join us next week, and thanks to everyone. saying bye now.
Thank you, Gregg.
Thanks a lot.
Feel the fear in my energy.